In a single moment, everything can change. But at GBMC, you're never alone. With a compassionate care team and today's advanced technology, we face the toughest moments together. Every milestone reached, every bell rung. No matter what, GBMC is here for life's moments.
Welcome to the NoPixAfterDark podcast. I'm your host, Aaron Dante. We are here live at GBMC this evening for a special event. First, I want to say Happy Women's History Month. This is something that we were planning for 6-7 months ago to make this event happen. Especially in NoPixAfterDark, we always try to do something great every Women's History Month. Every year we do something with women, celebrate women. A couple years ago, we did something with chefs, female chefs, and just a lot of these female chefs are on national TV right now, which was a really amazing event. So we try to highlight women every day, but especially Women's History Month. So today we have a great show for you guys. So the change explained by the menopause transition. And to my left, we have Dr. Dominique Allen, obstetrician and gynecologist for Capitals Women. The middle, we have Dr. Joan Blomquist, chair of Department of Gynecology at GBMC, and Dr. Elissa Trieu, Gynecologist and Surgeon at GBMC. Welcome, ladies.
Thank you.
I'm gonna have each one of you guys kick it off and tell background about yourselves. Dr. Al?
Yes, so I've been here at GBMC for what will be 31 years in July. So I did my residency here, loved it enough, and stayed for my entire career, and it's been an absolutely wonderful place to work. I do OB and GYN, so 50% OB, 50% GYN, so I see a full scope of women and take care of all of women's health care.
And I'm Joan Blomquist. I've been here 30 years this July. I came after I finished my training, and Dominique was one of the chief residents when I started, so I've known her the whole time I've been here. And I started as a general OB-GYN, and then after I did that for a few years, I decided to do some extra training in urogynecology and pelvic reconstructive surgery, which is what I focus my practice on now. And then over the last 4 years, I've been the head of our GYN department here. So kind of oversee these guys a little bit and help guide the direction of where we're going. And one of the things we're working on right now is improving our women's services here at GBMC. So this is one of the areas that we're really trying to expand and make sure that we're addressing all the issues and the needs of women and the physicians who work here.
Thank you. Hi, everyone. I'm Dr. Elissa Trieu. I'm one of the minimally invasive GYN surgeons here at GBMC. I will say I'm the newest one out of this entire group of 30 plus years at GBMC, but it's been excellent here so far. I focus a lot on fibroids, abnormal uterine bleeding, endometriosis, pelvic pain, ovarian cysts, a lot of these issues that tend to flare up during menopause and be a big issue during the perimenopausal transition. So I'm very excited to talk about that today.
Thank you so much for everything. Real quick, how did you guys get into this profession? Just want to know a little background about why and how you got here.
So I would say that just the idea of being able to do something on a daily basis, that I can do surgery at one point of the time, I can see patients at another point of the time, and obviously a great part of it is delivering babies. That beautiful, array of skill sets that I get to do on a daily basis, it's just a natural draw.
Yeah, I agree. I think just the physiology of the female body and reproductive system still amazes me. And so I just find it, scientifically intriguing and challenging. But it's also the way we are primary care providers in one sense of taking care of women across the whole lifespan. But then we also can specialize and do very specific surgical things.
To echo what Dr. Blomquist just said, it's hard not to love women's health. It's great to be an advocate for 50% of the population that often has very specific needs. I remember as a medical student, someone once said, no other organ in the body is the subject of culture, families, politics, media. And so this is such an important part of everyday life.
Thank you. All right, Dr. Trieu, we're going to start with you.
Excellent.
The word perimenopause has become more common recently, but many women still don't recognize when they're living it. What are the 2 or 3 signs that should make a woman say, I need to talk to my doctor now?
Okay. Well, Aaron, thank you for that question. I think that is a very great question to start us off, but also difficult because it's unique to each individual who's experiencing perimenopause. But at the same time, there are common symptoms that do have treatments that patients should bring up to their physicians. So first of all, anything that's affecting your quality of life. So hot flashes, vasomotor symptoms, sleep disturbances, night sweats. These are all things that are very common but also do have treatment options. And so I want people to know that. And then from my perspective as a GYN surgeon, I really focus on abnormal uterine bleeding. Abnormal bleeding is normally one of the first signs of perimenopause. Your periods are going to start becoming more frequent. There's more irregular spotting. Periods may become longer. And so if your bleeding is so heavy that you're soaking through pads, you feel anemic, weak, tired, anything that sort, then we want to know about it because it could be things like fibroids, adenomyosis, polyps, things with treatment and not necessarily just hormones.
Thank you. Dr. Blomquist, hormone replacement therapy had a major credibility crisis after the 2002 Women's Health Initiative study. How has the clinical guidance evolved since then, and what do you think wish more women understood about HRT today?
Right, we could spend the entire rest of talking about this, but I'll just sort of give a little brief summary of what the WHI study was and kind of why it came about, and then what impact it's had on what we've really done the last 25 years with regards to menopause care. So first of all, Premarin was first approved for treatment of hot flashes in 1943. So it's been around for a very long time. And it was approved because it's very effective in treating the vasomotor symptoms of menopause. And then in about the mid-1970s, and when we realized that estrogen alone for women with a uterus can cause endometrial cancer. So then all of a sudden there was concern about it. But pretty quickly we learned you can add progesterone and protect the uterus. And again, from most of the 80s, women were happy with their Premarin and progesterone. And then between the 80s and 90s, there was a lot of question about, is this good or is this bad for the heart? There were studies that showed that some women who were taking hormones were less likely to get heart disease, and other studies that showed the opposite. And so the WHI study, which stands for the Women's Health Initiative study, was really designed to determine whether or not taking hormones would protect our hearts. So should we all take hormones at menopause to prevent cardiovascular disease? So that's why the study was done. And there were 2 arms to the study, those who had a uterus, who needed estrogen and progesterones, and those who did not have a uterus, so needed just estrogen. And then there were 27,000 women in the study, so it was actually a very well-designed study. And they followed these women. The idea was to follow them for like 15 or 20 years. But the study was stopped short because in the arm of the woman who still had their uterus, there was a checkpoint where all of a sudden there was a higher risk of breast cancer. And so the study was kind of abruptly stopped. The problem was that all of the data hadn't really been analyzed yet. And it was talked about on the media, sorry to say this, on the media before it was even shared with providers and before the scientific paper was written. So as providers, we had very little knowledge about why was this stopped. Everybody was scared. Patients were scared. Providers were scared. And so people suddenly stopped using hormones. And as that study was further analyzed, what we really found was that difference in breast cancer was actually not statistically significant. The other arm of the study of women who did not take the progesterone actually had a lower risk of breast cancer. And there were lots of benefits of hormones that weren't talked about, like osteoporosis and decreasing fractures and a decreased risk of colon cancer. And that, yes, it does still really help your hot flashes and night sweats. So, we kind of lost sight of that with the big scare. The other thing that we've looked at over the last 20 years is the timing of when the hormones have started, which seems to make a big difference. That if you start hormones within the first 10 years after menopause, that the benefits seem to outweigh the risks. It doesn't mean after 10 years that it's a big no, but you need to very carefully analyze someone's risk of heart disease or stroke or things like that before automatically starting it if it's been more than 10 years since menopause. The other thing that we found is that the route of how we give the hormones matters. So in this study, it was Premarin, which is a synthetic, well, not synthetic, it's from horse urine, but it's an oral medication. We now know that the transdermal, so patches and gels and creams, are actually much safer than the oral route because they don't have to go through the liver. So they don't have an impact on clotting, and they're just considered much safer. So, things had really changed it's unfortunate that it took us 25 years to get here. But we now know that hormones are really much safer than what was touted back in 2002. But it's very important to think about timing, dose, and route, and individualize it and really have a good discussion with your provider as to what's best for you.
This is for Dr. Allen, Dr. Blomquist. Maryland has a diverse patient population across income levels, geography, and race. How does that reality shape the way women in our state actually experience or don't experience midlife healthcare?
So that's an excellent question. What is known is that certainly for African American women, you're going to tend to experience your menopausal symptoms or perimenopausal symptoms earlier. They're going to be more severe and they may last longer. And the other thing that goes along with that, which is a very sad fact, is that despite the fact that all those things exist, the treatments for that subgroup of population is less. So that's a very sad state, and that is not just here within Maryland, but that is a nationwide known fact. And so we have to be very mindful when we've got our patients coming in who might be a little bit younger or who might be complaining of, symptoms that seem a little bit more severe, that this is a reality for that subgroup of population or people. And so we have to be very mindful about that.
Well, to follow up real quick on that,
Sure.
how young have you seen this just in this population?
Right. So typically the perimenopause will be that about 10 years before your average age of menopause, and average age for menopause in the US is 51. So typically you start to see it. For the majority, it's that late 40s, but we'll see it, the early 40s. Or if you've got a family history where your mother stopped her periods at 45, maybe then you're going to start seeing those symptoms at 35. So we just really have to be very mindful of everybody's family history, what their symptoms are, and not ignore symptoms that we might have in the past. Part of the issue is with WHI is that we sort of fell off the, route of how we treat patients for a good 20 years. And so there's actually a subset of generation who just don't know that much about hormones unless you actually go out and study it. Like, we are mature enough to know what it looked like when we prescribed, when I first started, as soon as everybody hit menopause, they came into the office, we sat down and we started everybody on hormones. That was just what we did. Then WHI comes out and then nobody took hormones. And so then in that period when everybody's getting trained, there was a lack of knowledge as to what we're supposed to do. So now we've, swung back, so we're getting that knowledge again.
I guess just to add to that, just the question about, healthcare in Maryland in general. We're fortunate in Maryland that we have reproductive health laws that are promotional for women. And what that means with regards to OB-GYNs is that nationwide, there has been a decline in OB-GYNs just over the last 5 to 7 years because of the change in the laws, but it's more so in some states than others. So if we look at trends in Maryland, we expect to see a decrease in OB-GYNs, but not nearly as much in a lot of other states. So we're fortunate with that. There still are going to be areas, some of our more rural areas where there's, certainly still some gaps. And one of the things I think is really important with regards to menopause care is that we encourage OB-GYNs to be knowledgeable about this, but also primary care providers. So it doesn't just have to be your GYN that you can talk to about this. It should be your primary care or whoever your primary health care provider is. And there really is a big push across the nation to educate everybody on menopause. So hopefully we'll start to see that change.
Great. Dr. Blomquist is right there again. A woman comes in with joint pain, brain fog, and mood changes. Her thyroid looks fine. She's been tested for lupus, fibromyalgia. Everything comes back negative. What are you thinking as our clinician?
Well, since we're talking about menopause, that has. But I think the point of that question is obviously a very specific patient question, but in general, a lot of the symptoms of menopause can mimic other things. So we traditionally think hot flashes and night sweats, but it can be joint pain, it can be fatigue, it can be headaches, it can be difficulty sleeping. There's a lot of other things that sometimes are blamed on other things where you go through all sorts of testing. And it's always good just to think, could this be my hormones? And perimenopause, in particular, the hormones are, doing these huge ups and downs, and those variations for a lot of people can cause a lot of those type of symptoms.
Thank you. Dr. Allen?
Yes.
When it comes to hormone delivery pills, patches, creams, pellets, how do you decide what's right for the patient? Is there a best option, or truly it's for individually?
So Dr. Blomquist did start to address, sorry guys, that question. What we do know from WHI and all of the studies that have followed that related is that for certain transdermal hormones are going to be the safest route. There are certainly women who can't tolerate a patch. And so for that group of women, you can do a cream or a gel, but definitely having that transdermal approach for hormone replacement therapy is going to definitely be the safest route.
Women, going back to that gal, women are living 30 to 40 years post-menopause. Does the clinical approach to hormone therapy change over that timeline? And is indefinite HRT ever the right answer?
So this is treatment that has to be individualized. So you'd have to take each patient, see what their medical history looks like. There is an indefinite drop-off. So ACOG has firmly come out, who is our governing body for what we do nationally, and said that there was a thought that 65 was the stopping point, but it is not. And so you really have to take each patient individually, look at their medical history, and reevaluate on a year-by-year basis to see if they still remain a good candidate for hormone replacement therapy. But there's no particular stopping point. It just depends on how those symptoms are, and I encourage my patients to take a patch holiday or a pill holiday as it is, not in the hot Baltimore summertime. That would be rude. But in the winter, and see, do you still need your hormones, right? And then that way we can have a really thoughtful conversation when you come in for that office visit.
All right, Dr. Blomquist, how should a woman actually vet a gynecologist for menopause care? What questions should she ask to know whether a provider is up to date with current guidance?
So that's a good question. And, obviously, hopefully you have a good relationship with your gynecologist that you feel comfortable with asking these kind of questions. There is the Menopause Society has a certification process. So some people do become certified, and there's a list on the Menopause Society of people who are certified, although it's not really up to date, I've noted. But it is there, or you can ask if they have an interest in menopause. Some people don't do the certification, but it doesn't mean they're not knowledgeable on it and had an interest in it. So I think it's just important to ask that question, and ask the people in the office should be able to tell you that. But then the other question is, when you start talking to someone, if they offer you one thing and only one thing and don't give you other options, then that might just be all they're familiar with. So, I would make sure that you feel like you're being given choices of different things to really deal with any of your symptoms.
All right. This is for their whole panel.
Excellent.
What's the one thing about perimenopause and menopause that you find yourself explaining over and over again? The myth or misconception that you wish would just disappear?
All right, I'll start that one off. One of the big myths that I wish people would stop talking about is how you should just wait out the irregular bleeding that comes along with menopause. We have so many patients, I see them on a daily basis, patients who have heavy amounts of bleeding, who are anemic, fatigued, who are not going to social events because of pelvic pain and irregular bleeding. And they're told, hey, just wait it out a couple of years and then your bleeding will eventually stop. But that's not a good answer. One, menopause is 12 months without a period. So that's a moving target, and it's very different for different women. We have some patients who are 55 and still haven't fully gone through menopause yet. And so those are a lot of years in which people are just dealing with these symptoms. Two, fibroids are very, very common. And while fibroids tend to shrink with menopause, they might not completely go away. And depending on their size, they can still cause bulk symptoms, push on your bladder, your bowels, and provide issues even after your bleeding actually stops. And then I feel like there's this big misconception about the word surgery. People are very worried and they think that if I come in and talk about my irregular bleeding, they're just going to make me get a hysterectomy. But that's not true. Like Dr. Blomquist said, you want a provider that sits there, goes through all of your options with you, really tries to figure out what your symptoms are, how close you are to menopause, what your pathology is, or what's causing your issues, and then will help come up with a plan that gets you through this perimenopausal transition. We have a lot of new technologies that are very minimally invasive now that can preserve the uterus. GBMC actually has this new technology called the Elissa that can sort of zap the fibroids and cause them to slowly die over the course of months to years, months to a year, with a very quick recovery time. So I think people should realize that in this day of minimally invasive surgery, we're looking at recovery times of days to weeks, not months, as people sometimes think. So if you have an issue, go get it checked out.
And there's medical options too, right?
Yes.
Not just surgery, but
Absolutely. But I feel like we've touched a lot on the medical options, and don't worry. I think that's one of the aspects that we would sit there and talk about, because if the cause of your abnormal bleeding is hormonal, medical options are excellent. And we have so many different medical options.
so mine as a urogynecologist is vaginal estrogen. So that's something that I talk about probably 10 times a day at least. And until just this November, there was a black box warning on the vaginal estrogen saying it increases the risk of cancer and things, which was never true. That black box warning is finally gone. We know that using estrogen in the vagina can be very helpful for pain with intercourse, for vaginal dryness, for recurrent urinary tract infections, and overactive bladder symptoms like urinary urgency and frequency. And it is completely safe to use. We know that minimal, if any, gets absorbed into the bloodstream. It's even patients who've had breast cancer in the past are considered safe to use vaginal estrogen. So that's the thing that I feel like I'm constantly trying to, encourage people to try it.
And these ladies already know my pet peeve are lab levels. So there is no level at which I can tell you that menopause is coming tomorrow, next year, next month. So all of these panels that you want to have done, they have no relevance because your levels are going to go like this through the entirety of menopause. But that doesn't keep the telephone calls from coming, or even providers who are not sure, who get sort of bullied into doing these levels, for sending these levels to my office, and they're not inexpensive, and having them done, and they have no relevance. The one lab level that is very relevant is if you have no bleeding because you have an IUD in place, or you're in continuous birth control, or you've had a hysterectomy leaving your ovaries in place, or an ablation where you won't actually be able to define menopause is that absence of without periods for 12 months. There's one lab level, and it's just for that. Everything else, it's a wash.
Couple questions. Also, from a male perspective, how should husbands, boyfriends be supportive? And I think that's really important. And that's why I'm doing this, because I can't wait for them to listen and watch on YouTube. How do you, as far as doctors, what advice would you give to the males who are trying to understand and learn a little bit more about this?
Buy some sweats, because your wives are going to be in very skinny pajamas with a fan going on, and you just have to buy a lot of sweats and a hat.
I think exactly what you're doing right now, though, is a great way to address it. You are taking the initiative to go out, learn more. You recognize that this affects your sisters, wives, friends, colleagues, and that this is going to affect 50% of the population. So I think just getting educated, supporting women in whatever they need are excellent steps forward. And the sweats.
Yeah. Sweats for sweats.
If we're about patients who are looking to find new doctors now, is there a problem with wait times, or people are impatient, they feel like they're going through? What do you see to those patients out there like looking? I need help, but it takes 3 months here, 6 months here. What do you say to that? I mean, I know you said there's a shortage right now. So how do we counter that, and as far as from your perspectives?
So, number one, it's definitely true. It's a long wait for a lot of OB-GYNs just in general. But if you can always talk to your primary care provider, and that's a good place to start. Plus doing some reading. And this is something that actually Dominique and I had talked about a little bit, because if you Google, what oaks are good for hormone, you're going to have a list of like 100 different things. So it's really hard to figure out what's good information and what's not good information. But there is a book that just was published at the end of January by the American College of OB-GYN on what your gynecologist wants you to know about menopause. And so that should be a good resource. It just came in this week too, so I haven't read it thoroughly. But in general, that would be, from medical groups would be a good resource.
And do you have any final thoughts for the people who are listening today, who came out, who are listening, they'll be listening and watching, just about this topic and how important this is and how it's important for women in general, just for people in general, just your last words.
So echoing again what Dr. Blomquist said, using really reliable sources of information, because there is a lot of money to be made in this space and we're all in need. And so to that end, there's a lot of misinformation out there. So going on ACOG's website, going to the Menopause Society's website, then you're going to get valid information and not just something that's somebody's opinion or a way for them to, generate income.
We're not Googling or Google.
Don't go.
Don't.
Go Google yourself.
Right.
Yeah, and I hope what everyone's taking away from this is that there are a lot of associated symptoms with menopause, but there's a lot of treatments out there too. And there's a lot of new medications and different technologies and therapies that are being developed all the time. And so I think it's worth doing your reading, doing your research, and talking to your doctor to figure out what's right for you.
Yeah, I agree. And as you said, there's actually quite a few new non-hormonal, two new non-hormonal options, but also just some general non-hormonal options. So, if hormones is not something you're interested in, it's not like that's the only answer. So there's definitely some other things out there as well.
And I know, how can people get a hold of you? I know you guys are busy, but can they send you an email? Can they send you a tweet? What's the best way of communication? Because everybody's so accessible now. People are so accessible nowadays. It's like, it's like two people away to get a hold now. So it's kind of like if I want to find somebody, I'll find one social media. Right. Probably respond.
Yeah. I mean, generally through our website, and at least on our department website, there's I think it's Urogyn, another email, GBMC, urogyn@gbmc.org. Is that correct? So that gets our whole office staff. And all the GYNs at GBMC are listed. You go to the GBMC website under Find a Doc. There's a whole section on all the gynecologists who are available.
Thank you. Well, thank you for your time. Thank you, everybody. If you guys stay afterwards, we're going to ask some questions that you might have. We're not recording that part, but thank you for your time. Thank you guys for coming out on this sunny, snowy, funny, yes, I've also second spring and second winter. Thank you so much. Have a good night.